So we'll go for the staging. Mainly staging is nothing but staging of colon and rectum. Along with rectum, what important are there in the staging, we'll just quickly go through, because based on the staging only all treatment will evolve. Staging in colorectum is, if tumor, suppose this all staging will be done by the radiologist and pathologist, and specifically in the rectum, radiologist is equivalent to the pathologist. Based on the mercury trial, they have come to very close to the pathological staging. Means if specimen has been staged by MRI and specimen resected staged by pathologist, almost equivalent. That precise staging they are giving. In that staging, tumor is related to mucosa and submucosa is T1. If it is going to the muscle layer is T2, crossing the muscle, then it is T3, and if it is going to the peritoneum or organ invading is T4. If it comes to rectum, again there is T3 is divided into A, B, C, D. Why? Because T3A and T3B, which are located away, if it is a posterior rectum we are taking, it is never going to be circular, it is uneven, anteriorly very thin, laterally bit of thick, and posteriorly bulk of fat will be there. If we are having posterior tumor, if it is A and B very close to the rectum, in those patients we need not to radiate, we can go ahead directly with the surgery as per the European concept. And if we are taking the tumor at the level of 15, more than 15 mm, so it will go close to the mesorectal fascia. Those tumor need a upfront either short course or long course, and depends upon the center policy. For that reason, in rectum again they have divided into T3 ABC, and rectum again there is an involvement of peritoneum. If you see rectum, I have given the concept that rectum is divide of the peritoneum at the lower part, but in upper and middle part, anterior and anterolaterally peritoneum is there. If tumor is invading to the peritoneum, it is a T4A. It has a better survival as compared to T4B. If it is a low rectum, definitely it will evolve into the prostate and seminal vesicle. In those organs, prostate, seminal vesicle, or uterus or bladder, in those organs it is called a T4B. In fact, T3 also divided into MRF positive, MRF negative, because if it is less than, if suppose this tumor which is touching the mesorectal fascia or within 1 mm of mesorectal fascia, that is MRF positive. If it is more than 1 mm, where mesorectal fascia is not threatened or CRM is not threatened, that is called TRF negative, T3 MRF negative. Those tumor are not a directly candidate for going for long course chemotherapy. So whole staging of colorectum is same, but rectum T3 has been more highlighted because T3 tumors are more, and T3 early tumor and T3 late tumor has their own different protocol for management. For that reason, we have to understand the concept. So we'll go quickly through all the things. AGCG 8th stage, they have given a important is T3 divided into 4 stages, not in AGCC. It is based on the European studies. T1 is submucosa, mucosa. T2 is muscularis. T3 is perirectal or pericolorectal tissue involvement. T4 is A is peritoneum, B is adherent to organ. T3 subdivided into 4 types: less than 1 mm, 1 to 5 mm, 6 to 15, more than 15, not based on NCCN or AGCC, it based on the European studies. Nodal status, node N1, N1 or N2. N1, in N1, 1 node positive is N1A, 2 to 3 node positive N1B, and also there is no tumor, but there is a deposit, tumor deposit is there. That concept I will clear later on, yeah, while doing the MRI. That is a N1C, where there is no node, but there is a tumor deposit. N2 4 to 6 node, and N2B is more than 7 nodes. Distant mets M1A metastasis to one site or organ without peritoneal mets. M1B is 2 or more organ without peritoneal mets. M1C is peritoneal surface mets with or without organ mets. So peritoneal mets has been given M1C because its prognosis in colorectal malignancy is something worse as compared to organ involvement, other organ involvement. Liver is better than the peritoneum. Liver, lung, even isolated, we are planning for the resection, a definitive curative therapy we are planning in the colorectal mets. If it is a peritoneal, peritoneum also option of HIPEC is there, but peritoneal disease behave worse than the organ involvement. So for that reason, prognosis is different. One organ involvement or one site involvement without peritoneum is good prognosis. Two or more organ, liver and lung both involved without peritoneum is bit of better prognosis. If peritoneum is involved with or without organ or surface is worse prognosis. So M1A, M1B, M1C. Changes what happened in AJCC 8 is they have given M1C category for peritoneal carcinomatosis with or without blood-borne metastasis to organ, because patient with peritoneal mets have shorter progression-free survival and overall survival than those with without peritoneal involvement. That's what these patients will be very bad. But there also we are having now a treatment of hyper. Now, P is mentioned for pathological staging. YP for post neoadjuvant means chemo RT has been given. Those are YP. C has to be mentioned clinical staging. U has to be mentioned for ultrasound based. MR is MR based and P is pathological based. CT is CT based staging. So these are the prefix. If there is a presence, according to that we have to decide, is it clinical, is it a ultrasound based, or is it a pathological based, or it is a post neoadjuvant chemo RT based staging. That's all. 8CG manual note that micromets, this is also one concept, good concept. Micromets are defined as 10 to 12 tumor cell or clump of the tumor more than 0.2 mm diameter. Recommend that these micromets are considered as a standard positive nodes if it is a 10 to 12 tumor cell or clump of the tumor more than 0.2 mm, that is supposed to be considered as a standard nodes. And if it is a less than that, it is a tumor deposit. AJCC and CAP, Clinical Pathological Association, they recommend that at least 12 nodes should be, 12 node is important. If retrieval less than 12 node in colorectal disease, that is considered to be inadequate surgery. It is pertaining to upfront surgery. If you are given chemo RT or chemotherapy and then you are counting the node, it is not applicable. Tumor deposits are irregular discrete tumor deposit in the perirectal fat that are away from the leading edge. Means you are having the tumor at the center. Suppose this is a tumor at the center and away from the tumor there is a something tumor deposit, that is called N1C. No evidence of regional nodes are there, but within the lymphatic drainage of the primary tumor. This is located within the lymphatic drainage, that is called as N1C. This N1C concept is only pertaining to colorectal cancers. Not counted as a lymph node replaced by the tumor. It is not counted as a lymph node replaced by tumor, but tumor deposit itself is due to lymphovascular invasion or occasionally perineural invasion.